Hello again, this is Anil here at DiCarmel NCLEX review program. I'm here to help you pass your NCLEX exam much easier than what you thought. And at times, many students are challenged with some topics that come on NCLEX preparation, and I'm here to help you understand some of those harder ones. And the one I have chosen for the day is cyanotic versus acyanotic heart defects. And in order to understand the difference between acyanotic and cyanotic heart defects, let us look into what is happening with the fetal circulation. So let's start from there. So I'm going to show you some images here, as you can see. So within this image, you will be able to identify some important parts that are very unique for the fetal circulation and what we call as a fetal adaptations. Okay? And why there are such adaptations. And to understand that, let's look into the difference between the intrauterine and the extrauterine circulation. So we know within the extrauterine circulation, our lungs are fully functional, our heart is functional, right? Okay. So we are able to breathe in and breathe out, all the exchange, everything takes place in our lungs. But that's not how when it comes into the intrauterine life. We know the fetal lungs are still not functional yet, they are in a collapsed state. Okay. So that's one of the major difference between the extrauterine and the intrauterine life. And in order to match with this unique situation of the fetal lungs, that's where all these adaptations are in place. And let's look into these adaptations a little bit one by one. The first adaptation, as you can see, is called a ductus venosus. So what is ductus venosus? As you can see, it's a connection between the umbilical vein and the inferior vena cava. So it's a connection of two veins. So that's a ductus venosus. And as I told you, the fetal lungs are not functional yet. They are in a collapsed state. So how do the baby breathe? So they get the ready-made oxygen coming from the mother via the umbilical cord, which is poured into the inferior vena cava, and that connection is what we call as ductus venosus. So now that the blood is in the inferior vena cava, it flows as usual into the right atrium. But what happens, there comes the next adaptation. And again, remember, the fetal lungs are in a collapsed state. Okay? So if the blood, as you can see, if the blood that is coming into the right atrium, normally it goes into the right ventricle, from there it gets pumped into the lungs via the pulmonary arteries. So that doesn't function properly here. Again, remember the reason, the lungs are in a collapsed state. And to overcome that difference, so that's where other adaptations are in place here as well. And as you can see, a second adaptation is what we call as Foramen Ovale, so which is a direct connection from right atrium to the left atrium. So which means the blood that is coming to the right atrium is poured into the left atrium via the Foramen Ovale. But then a part of the blood coming to the right atrium also comes to the right ventricle, from where it gets pumped into the lungs via the pulmonary artery. But then that blood doesn't really reach all the way into the lungs. Again, remember, the lungs are in the collapsed state. So what happens instead? So the blood that is flowing through the pulmonary artery is directed into the aorta via the next adaptation, what we call as ductus arteriosum, which is a connection between two arteries, right? Pulmonary artery and aorta. So it's called the ductus arteriosus. So whatever blood that flows through the aorta goes through the thoracic aorta, the abdominal aorta, and by the time it reaches to the level of pelvis, it is almost deoxygenated. Remember, this blood is coming from the mother, it's a long way, and the blood is almost deoxygenated. So it doesn't make real sense for the blood to flow all the way to the tip of the lower extremities. So instead, the blood gets redirected back to the mother via two arteries originating from the internal iliac arteries, what we call as hypogastric arteries. And it is those hypogastric arteries eventually become the umbilical arteries. So remember, it started with the umbilical vein from the mother, which is bringing the oxygenated blood to the baby. And now the deoxygenated blood from the baby is going back to the mother via the umbilical arteries. So that will complete the fetal circulation. And again, recollect the four adaptations we heard here, which includes ductus venosus, that's a connection between inferior vena cava and umbilical arteries. And then foramen ovale, which is an opening on the atrial septum. And then ductus arteriosus is a connection between pulmonary artery and aorta. And finally, hypogastric arteries, those are the arteries which eventually become the umbilical arteries. And here, the fetal circulation gets completed. So let's try to understand what happened at the time of birth. When we cut the cord, the blood flow through the umbilical vein and the arteries will stop. And also remember, the moment after the birth, the baby cries, right? When they cry, what happened? The lungs expand so that the blood from the right ventricle can easily flow into the lungs and it can undergo the exchange process for the first time. So now that the oxygenated blood starts to return to the left atrium via the pulmonary veins, right, which is bringing the pure blood, the oxygenated blood from the lungs back into the left atrium. So when this sudden increase in the blood flow from the lungs to the left atrium increases, with that increasing pressure, the foramen ovale will temporarily close, so that there is no more blood flow between right and the left atrium. And so as with the changing pressure, then that will also lead to increased blood into the left ventricle, and that blood starts to flow smoothly through the aorta, and as the pressure in the aorta increases, the ductus arteriosum also will close. And with this change in pressure in the aortic circulation, the hypogastric arteries also will collapse. So now the baby is into the extrauterine circulation. So this is what happens in normal. And again, we need this background information to better understand the difference between acyanotic and cyanotic heart defects. So now let's proceed into the difference between acyanotic and cyanotic heart defects. And probably you have heard when we talk about acyanotic defects, we call it as left to right shunt, whereas with the cyanotic it's called right to left shunt. And let's see what this exactly mean and why they are called acyanotic and cyanotic. So here I'm going to bring up a list of topics. In fact it's a long list. I have 6 of them, as you can see, of acyanotic defects, the classic ones that are listed here. So that include ASD, VSD, PDA, coarctation of aorta, pulmonary stenosis and aortic stenosis. So let's look into these topics briefly. So starting with the first one, as you can see in this image, again remember these are called the acyanotic defects, and these are characterized by left to right shunt, which means blood from the left side can get into the right side, and the blood that is being pumped out of the left ventricle, remember the aortic blood, that is always oxygenated, so it doesn't cause any cyanosis. That's what is called acyanotic. And let's look into these conditions one by one very briefly. So the first one we have here in this image, as you can see, yes, that is ASD. And what do you see there? You see a large opening on the atrial septum, probably is pretty close to the location of the foramen ovale. Remember we heard about the foramen ovale, which is a natural opening that is there in the fetal circulation. But that would close at the time of birth, as we heard. But in some rare conditions, because of what is happening with the mother, maybe the effect of various disease conditions such as rubella, or maybe some medications that the mother has taken, what we call as a teratogenic drugs, so which can cause damage to the different parts within the heart, and which can cause an abnormal opening on the atrial septum, and that's what you see here called an atrial septal defect. So as you can see what is happening, blood from the left atrium is flowing to the right atrium, and then that blood goes down into the right ventricle and the normal circulation follows. But still, the blood that is getting pumped out from the left ventricle still remains oxygenated. There is no mixing. So that's why it doesn't cause no cyanosis, and that's why it's called the acyanotic heart defect. And now it's a similar mechanism which you can see with the VSD. What is happening with the VSD, which is ventricular septal defect? There is a large opening between the left ventricle and the right ventricle. So through that opening, blood from the left ventricle will flow into the right ventricle. So the blood that is getting pumped out from the left ventricle still remains oxygenated because there is no mixing, as you can see in this case. By the way, this time I want to bring your attention into a comparison of how the fetal circulation and the extrauterine circulation are different. And remember one thing, during fetal circulation, we were talking there is a foramen ovale, right? The connection between the right atrium and the left atrium, there is foramen ovale. So during fetal circulation, when such opening exists, what happened? Blood will flow from right atrium to the left atrium, or it's the right to left shunt. Because why? Because the pressure on the right side is more, and the reason the lungs are collapsed. When the lungs are collapsed, blood from the right ventricle cannot go into the lungs. So overall, the pressure on the right side is more, and that's why when there is presence of the foramen ovale, it will cause the blood to flow from right atrium to left atrium. It doesn't go the other way. It is from right atrium to left atrium. But now here with the ASD and VSD, we are talking when such openings exist, blood is flowing the opposite way. And the reason, after birth, remember the lungs are no more collapsed, they are functional, they open up, they have full exchange process. And as the blood starts to return via the pulmonary veins to the left atrium, the pressure on the left side increases. So that means before birth, pressure on the right side is more than the left side. But after birth, pressure on the left side is more than the right side. So that's why when there is with ASD and VSD, always blood flow from left side to the right side. Now, the third condition in the list is PDA, that is patent ductus arteriosus, and as we heard, it's a connection between pulmonary artery and aorta. And we heard during fetal life what happened, blood that is flowing through the pulmonary artery, it will get directed into the aortic circulation. So remember again what I just told you, the pressure on the right side is more than the left side, and so was pressure in the pulmonary circulation is more than the aortic circulation. So with that increased pressure, blood will flow from pulmonary artery into aorta. But then what happened after birth? We already heard pressure on the left side is more. Pressure in the aortic circulation is more than the pulmonary circulation. So with that increasing pressure, the ductus arteriosus closes temporarily, and within few weeks it will get totally closed. So that's a normal mechanism. But sometimes it can still remain patent, and that's when we call it as patent ductus arteriosus. And what is happening in PDA, like if blood is flowing through the aorta, as we heard, the pressure in the left side and in the aortic circulation is more than the right side. So the blood that is flowing through the aorta can now flow back into the pulmonary circulation. The pulmonary circulation is just leading into the lungs. So, the oxygenated blood that is getting pumped out via aorta, it gets pumped back into the lungs, causing pulmonary congestion. Now we have the fourth classic condition in the list, which is coarctation of aorta. And as you can see here in this image, what is the normal structure of the arch of aorta and the descending aorta versus what you see here with the coarctation. And it's clearly evident. You can see a narrowing of the descending aorta, which is just distal to the 3 aortic branches, and that's another thing you must know. And as you can see, there are 3 major vessels arising from the arch of aorta, which include right brachiocephalic and the left common carotid and the left subclavian. And these are the 3 vessels which are supplying to the upper extremities and to the head. So after giving away this blood to this area, the aorta narrows, and that's what we call as coarctation of aorta. So what is the outcome? It's going to cause too much blood flow to the upper extremities and to the head, and reduce the blood flow to the lower extremities. So it can cause warm upper body, cool lower body. Too much blood flow to the brain maybe can cause stroke. Increased pressure in the upper extremities and decrease in the lower extremities. So it is clearly understandable how coarctation can cause these differences, again because of the narrowing of the aorta just distal to the 3 blood vessels that gives the blood flow to the upper extremities and the head. And the 2 remaining conditions are much more easy to understand. You can see here pulmonary stenosis, which is narrowing of the pulmonary valve. And when there is pulmonary stenosis, what is going to happen? Blood flow to the lungs can reduce. That's going to cause too much pressure to build up on the right ventricle. So that's what is pulmonary stenosis. And whereas aortic stenosis is a similar mechanism, which is a narrowing of the aortic valve, which can cause too much blood to pool in the left ventricle, resulting in increased left ventricular pressure. And I hope this was clear so far with our acyanotic defects. And again, in none of these conditions, there is no mixing of the deoxygenated blood with the oxygenated. Rather, the oxygenated blood from the left side flows to the right side, and the blood that is getting pumped out via the aorta to the rest of the body remains still oxygenated. So there is no case of cyanosis here. Now let's go to how cyanotic defects are different. And as you can see, there are 3 conditions that are listed here. TOF, that is Tetralogy of Fallot, and transposition of great vessels, and truncus arteriosus. And the one I'm just going to focus here is TOF, and which is so classic on NCLEX as you would have seen already. So let's look into the details of Tetralogy of Fallot. And as you can see here, and as the term indicates, it's tetra means 4, right? It's a combination of 4 defects. And which are they? That includes pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and ventricular septal defect. So what do you see here? You see a combination of defects which we heard before under acyanotic defect. Didn't we hear already ventricular septal defect and pulmonary stenosis? They both exist here with the TOF as well. So there is VSD and pulmonary stenosis. But in addition, there are a couple other associated problems. So that include overriding of aorta. And what does that mean? So normally we know aorta is positioned into the left ventricle and is pumping the oxygenated blood from the left ventricle into the body. But here what happened, as you can see, so the aorta is kind of positioned to both sides. That's called overriding. So that means the blood that is getting pumped out via the aorta is a mix of the blood in the right and left. And also let me clarify how this right ventricular hypertrophy happens, which is the 4th defect under the condition. So what is actually happening here? Again, let me just show you the blood flow. So as you can see, in normal case, as we heard before, when there is an opening between the left and right after birth, so blood will flow from left to right. That's what you can see here. So via the large VSD, blood from left ventricle will flow into the right ventricle. But then in normal case, that blood will easily flow out through the pulmonary veins into the lungs. But what happens here, the other underlying problem, which is pulmonary stenosis. Because of the pulmonary stenosis, this blood cannot flow out, and that's going to increase the pressure in the right ventricle, and there will be a constant elevation of pressure in the right ventricle, and that's where the patient can also go into this compensatory mechanism, what we call right ventricular hypertrophy. So that's the fourth defect in the condition. Now, we are talking, so the pressure is going to increase in the right ventricle. So when the pressure increases in the right ventricle, what is going to happen? The blood from the right ventricle can flow back into the left ventricle via the VSD. So then it's a total mix of blood in the right and left. That's what you see. And it is that mix of blood which gets pumped out via the aorta to the whole body, resulting in cyanosis. So I hope you are able to differentiate clearly between acyanotic and cyanotic defects. And let me just brief that once more. In acyanotic defects, what happened, blood from the left side can flow to the right side. But the blood that is getting pumped out via the aorta still remains oxygenated. And that's why there is no cyanosis, and it's called acyanotic. But in cyanotic defects, the classic one, TOF, we heard, blood from the left ventricle can come to the right ventricle, but because of the pulmonary constriction, blood cannot go into the lungs, rather it's going to build up in the right ventricle, causing too much pressure, and because of the pressure, then our blood will flow back into the left ventricle, causing a total mix of blood in the right and left ventricle. And it is that mix of blood which gets pumped out via the aorta, resulting in cyanosis. Keeping this information in mind, I strongly believe now you will be able to easily differentiate and answer the questions related to acyanotic and cyanotic defects. And I'm going to definitely come back with a detailed review on Tetralogy of Fallot, which is another beautiful topic they ask in itself. Okay? And make sure you subscribe our channel so you wouldn't miss any of these important videos that can really help you pass your NCLEX exam. Thank you.